Hello and welcome to the CSF review of the APLAR 2021 Virtual Congress. My name is Professor Tsutomu Takeuchi from the Keio University School of Medicine, Japan. I'm joined today by my colleague, Professor Bong from the Seoul National University College of Medicine, South Korea, to review the key content relating to cytokine signaling that was presented at this year's Congress. This is the second year that APLAR has provided a virtual Congress, and I would say that it has been a huge success with the quality of the scientific content being very high. We will now review the most notable abstract from the APLAR 2021 Virtual Congress. We have grouped the abstracts into key themes. One, rheumatoid arthritis, including filgotinib, upadacitinib, tofacitinib, and baricitinib. Next, beyond RA, psoriatic arthritis, ankylosing spondylitis, juvenile idiopathic arthritis, and COVID-19 finally. Please enjoy the content. Rheumatoid arthritis. The cytokine signaling forum is especially focused on the use of JAK inhibitors in rheumatoid arthritis, and we will consider the result for these first. Our first abstract from the meeting focuses on BDMAs and JAK inhibitors in patients with rheumatoid arthritis, where the authors examine drug tolerability, reasons for discontinuations, and effectiveness in RA patients. So this is the first abstract. Effectiveness of biological DMARD JAK inhibitors monotherapy in patients with RA. The trial name is ANSWER Longitudinal Cohort Study. By this abstract, we show that the key result is 3 points. The data from RA patient treated with biological DMARD JAK inhibitor monotherapy, but not CS DMARD, were analyzed. Total number is 647 patients, including 194 CTLA-4 Ig, 215 IL-6 inhibitor, 66 JAK, and 358 TNF inhibitor. Drug discontinuation was highest for TNF inhibitor, mainly due to lack of effectiveness. That is significant. And then CS-DMARD were less likely to be added during IL-6 monotherapy, and JAK monotherapy were typically discontinued due to remission. The conclusion is here. CTLA-4 Ig, IL-6 receptor inhibitor, and JAK inhibitor monotherapies had superior drug retention and effectiveness compared with TNF inhibitor monotherapy. The next abstract considers filgotinib, a post-hoc subgroup analysis of 2 phase 3 trials authored by Yoshiya Tanaka and colleagues. The title of poster is Efficacy of filgotinib in RA by age, body weight, BMI, post-hoc subgroup analysis of 2 phase 3 clinical trials. The 2 clinical phase trial is a FINCH 1, that is MTX-IR, FINCH 3, that is MTX naive. The number of patients included in this clinical trial is more than 1,000, a huge clinical trials. The patients were analyzed for ACR20 at week 12 for FINCH 1 and week 24 at FINCH 3. The treatment with 200 milligram filgotinib had greater efficacy versus placebo, regardless of age, body weight, and BMI in MTX-IR patients. Also, it is true in MTX-naive patients, except those elderly patients, the age greater than 65. The TEAE rates were higher among elderly patients versus younger patients, and particularly in higher body weight patients, more than 100 kilogram in MTX-naive patients. A safety was comparable between BMI subgroups. The conclusion of this poster is that filgotinib 200 milligram was efficacious regardless of age, body weight, or BMI, and TEAE occurred most frequently among older patients and in MTX-naive patients with the highest BMI. Next one is upadacitinib. I will be presenting another abstract from Yoshiya Tanaka and colleagues on upadacitinib assessing the 84-week results from the select monotherapy trial. This is done by Professor Lee. Yeah, please introduce this upadacitinib trial, Professor Lee.
Okay, can you give me the next slide? Yes, this study is select monotherapy. So in this study, upadacitinib monotherapy was evaluated in rheumatoid arthritis patients who showed inadequate response to methotrexate. This is an 84-week trial. The key results were as follows. The patients on stable MTS was originally randomized to upadacitinib 50 milligram, 30 milligram, or placebo. And then this is the long-term extension result at 84 weeks. So 598 patients entered the long-term extension study, and 20% discontinued due to adverse event, consent withdrawal, or loss of follow-up or something. And the common treatment emergent adverse events were the urinary and urinary tract infection, creatine phosphokinase increase, nasopharyngitis, RA worsening, bronchitis, herpes zoster, ALT increase. And the switching from MTX to upadacitinib treatment demonstrates comparable efficacy to continued upadacitinib treatment. So in conclusion, the authors showed that no new safety signals were identified for upadacitinib 15 or 30 milligram monotherapy, which resulted in continued and sustained RA symptom improvement through 84 weeks. Next slide, please. Next is about tofacitinib. So moving on to tofacitinib, we have two abstracts exploring ACR response and impact on liver function in patients with rheumatoid arthritis. With the first study from Yuan An and colleagues assessing the characteristics and treatment outcomes of ACR20 responders to tofacitinib at month 3. Next slide. In this study, the authors investigated the characteristics and treatment outcomes of ACR20 responders to tofacitinib at month 3 in rheumatoid arthritis patients. This was a post-hoc analysis. The data from RA patients, over 3,000 RA patients who showed inadequate response to at least one DMARD and who received tofacitinib 5 milligram or 10 milligram or placebo. This was a phase 3 and 4 clinical trials. ACR20 response was at month 3 showed similar demographics and baseline disease characteristics. And responders are more likely rheumatoid factor and anti-CCP positive antibodies, but less likely to be rheumatoid negative, anti-CCP negative, less likely to receive MTX on day 1, less likely to have previously received TNF inhibitors. Responders had significantly higher DAS28 defined low disease activity, CDI defined LDA, and remission rate. Efficacy of the at 3 months was generally maintained up to month 12. Adverse events was similar between responders and non-responders. So in conclusion, we also showed that ACR20 non-response at month 3 in patients with RA predicted lack of responsiveness to tofacitinib up to 12 months. Next slide, please. Next slide is investigation about the impact of the topacid on liver function test in rheumatoid arthritis patients. This study, based on the data from phase 3 clinical trials, and the number of the patients is over 3,000 who received the topacid 5 milligram BID or 10 milligram BID or adalimumab 40 milligram every 2 weeks placebo. So AST and ALT levels were measured at baseline and up to month 3. And most of the patients showed normal or mild abnormal liver function test abnormality at first, at baseline. And patients with abnormal baseline ALT, AST levels usually improve the liver function test up to month 3. More patients receiving topacid 5 milligram BID. In these patients, who used the concomitant MTX, NSAIDs, or statins, had increased AST ALT levels by month 3 compared with the patients who take monotherapy topacid. So in conclusion, he also showed that in our patients receiving topacid, ALT levels are more likely to increase by month 3 in patients who receive combination therapy compared with the monotherapy. Next slide.
Thank you very much, Professor Lee. So the next one is baricitinib. Baricitinib is turning now to the another established JAK inhibitors. At this year's APLAR 2021, studies on baricitinib reported the efficacy, safety, and radiographic progression in patients with RA. The first study we highlight comes from Professor Smoren and colleagues who examined the efficacy of baricitinib in patients with moderate to severe RA with 3 years of treatment. That is this one. The title of poster is Efficacy of baricitinib in patients with a moderate to severe RA with 3 years of treatment, results from a long-term study. The key result here is the data were analyzed from RA begin, that is MTX naive, and RA B, that is MTX-IR, for 52 weeks, and the rate treatment extension RA beyond for 148 weeks, that is 3 years. After 52 weeks, RA begin patients were switched to 4 milligram baricitinib, and RA begin patients were switched to 4 milligram baricitinib plus MTX. By week 24 in RA begin, 62% of patients receiving baricitinib versus 40% of those on MTX achieved SDI-LDA up to 184 weeks. By week 24 in RAB, that is MTX-IR, 52% of bari-treated patients and 50% of other treated patients versus 26% of placebo patients achieved SDI-LDA. Finally, the DR for baricitinib treatment were slightly lower than those across all treatment groups in RA begin and RAB. So the conclusion here is long-term baricitinib treatment was well tolerated and maintained clinically relevant outcomes for up to 3 years. The next poster is this one, Safety of baricitinib in Japanese patients with rheumatoid arthritis. 2020 interim report from all case post-marketing surveillance in clinical practice. The key result is the one, all case PMS of baricitinib from September 2017, analyzed safety and effectiveness first 24 weeks, and SAE for 3 years. The total number of patients examined in 3,445, female of 80%, the mean age is 64 years. Mean RA duration is 12 years, received baricitinib as follows: 4 milligrams 60%, 2 milligram 7%, 4 down to 2 is 5%, 2 up to 4 is 5%, and others 2%. Concomitant MTX and glucocorticoid use was 65% for MTX, 48% for glucocorticoid. Among these more than 3,000 in a real world, 6 patients died, and AE and SAE were observed in 887 AE, 122 for SAE. The major AE included herpes zoster, that is 3%, liver dysfunction 3%, followed by serious infection 1%, anemia 1%, hyperlipidemia 1%, malignancy 0.3%, interstitial pneumonia 0.2%, MACE 0.1%, and VTE 0.1%. The conclusion here is data encourages guideline compliant baricitinib use due to lack of new safety concerns. So next one, incidence rate and characteristics of herpes zoster in patients, including Japanese, with moderate to severe rheumatoid arthritis. Update from baricitinib clinical studies. A key result here is incidence rate IR per 100 patient year of herpes zoster calculated for baricitinib treated patients, including phase 1 to 3 trials and long-term extension study with risk factors assessed by Cox proportional hazard models. All patients, 323 among 3,770, incidence rate is 3.300 patients a year, had herpes zoster as of February 2018. 4% with herpes zoster history, 3% with prior live herpes zoster vaccination. For example, the concomitant treatment, 80% MTX, 50% glucocorticoid, 8% cases were multidermatoma. The third bullet point is median time to first herpes zoster was 538 days. Patient percentage with herpes zoster, but not incidence rate increased with time. Risk of herpes zoster was associated with older age and Asian region, but not corticosteroid, history of herpes zoster, or baseline lymphocytes. The conclusion here is Japanese baricitinib treated patients had higher herpes zoster rates, but herpes zoster IR did not increase with time, and most herpes zoster were monodermatomal and uncomplicated. So next abstract is here. The title is Radiographic Progression of Structural Joint Damage over 5 years of baricitinib treatment in patients with RA, results from RA Beyond. RA Beyond is the patient recruited from RA Begin, that is DMARD naive, RA Build, that is CSD MARD IR, RA Beam, MTX IR, that were enrolled in RA Beyond. The key result here is among more than 2,000 patients, 82.6% of patients entered RA Beyond. And DMARD naive patients on initial baricitinib mono, MTX combination therapy versus initial MTX had significantly slower radiographic progression and fewer erosion. That is years 3 to 5, all significant. A greater proportion of patients on that therapy versus MTX monotherapy had no radiographic progression. That is also significant. Again, the baricitinib mono or baricitinib plus MTX combination is superior over MTX monotherapy in terms of the inhibition of joint progression. The third bullet point is among MTX-IR patients on initial baricitinib had slower radiographic progression than placebo plus MTX. That is comparable to initial adalimumab treatment, years 3 to 5. A greater proportion who received initial bari versus initial placebo had no radiographic progression. That is also significant. And finally, CSD-MAD-IR patients receiving 4 mg baricitinib had the slowest radiographic progression compared with initial placebo or 2 mg baricitinib. A conclusion here is, once daily baricitinib treatment maintained low radiographic progression rates for up to 5 years in various RA patient population backgrounds. So the discussion time for JAK inhibitors in rheumatoid arthritis. Please start, Professor Lee. Do you have any discussion points?
Oh, so there are several interesting abstracts about JAK inhibitor effect on rheumatoid arthritis in this APLAR. But I think that the general efficacy and safety of the all JAK inhibitors were very similar. So what do you think about your thoughts about the different kinds of JAK inhibitors in rheumatoid arthritis?
Yes, you're correct. Even though the patient with a different patient background, like MTX-naive, MTX-IR, or CSD-MAD-IR, the JAK inhibitor showed the superior efficacy compared to the placebo or even MTX in MTX-naive patient. But it is a little bit different from the dose of the each JAK inhibitors. The higher dose is much more in some JAK inhibitors, or it is comparable between the higher dose and the lower dose. However, the efficacy in terms of the clinical sign symptom reduction, as well as joint progression, is superior for JAK inhibitor over placebo. That is my impression.
I also agree with your opinion.
Do you agree? Okay.
Yes, I agree.
Yeah, thank you.
Because of the time limit, we'd better go to the next topic, I think.
Okay. Okay. Let's move to the next topics. Okay.
This is the psoriasis, right? So let's go to the next slide. While this was a good year for results in rheumatoid arthritis, we also saw some great submissions focused on psoriatic arthritis, ankylosing spondylitis, and juvenile idiopathic arthritis too. Most of the data highlights the safety and efficacy of novel and established agents, with the first study from Professor Lane McInnes and colleagues reporting the efficacy and safety of guselkumab through a 2-year phase 3 study. Next slide, please. Yes, this is a study which investigated the efficacy and safety of guselkumab, which is anti-interleukin 23 monoclonal antibody through 2 years. This was an extension from phase 3 randomized double-blind placebo-controlled study in active psoriatic arthritis patients who is biologic naive patients. So in this study, if you see the key results, the biologic naive psoriatic arthritis patients were randomized to guselkumab 100 milligrams every 4 weeks and every 8 weeks, and placebo. And the primary endpoint was week 24. So in this study, they showed the data at 2 years. So about 88% of the patients completed week 100, and ACR20 response rate increased from week 24 to week 100. So every 4-week group, it was 76%, and every 8 weeks, it was 74%. The other efficacy markers showed the similar results. And there was also low radiographic progression rate, which was measured with the Upadhye score during 50 to 100 weeks. So the change was 0.75 for every 4 weeks group and 0.46 for every 8 weeks, and it was 0.13 who changed from placebo to guselkumab. So adverse events were generally consistent with the 1-year data. So in conclusion, guselkumab benefit for joint skin symptoms, physical functions, and the low radiographic progression rate persisted for 2 years, consistent with the 1-year finding in biology-naive psoriatic arthritis patients. Next slide, please. This study is about the Upadhye safety and effectiveness of Upadhye in patients with psoriatic arthritis patients. This is 56-week results from select psoriatic A1 study. So this study was originally the patients received 50 milligram Upadhye, 30 milligram Upadhye, and adalimumab 40 milligram every other week for 56 weeks. And 83.2% of patients received at least one dose study drug and completed 56 weeks treatment. And ACR 20, 50, 70, and PASI scores and the resolution of encephalitis and dactylitis were maintained or improved over 56 weeks. And at week 56, improvements were similar for placebo to Upadhye patients and those originally randomized to Upadhye. And adverse events and serious adverse events were similar. Upadhye 15 milligram versus adalimumab, but slightly higher in Upadhye 30 milligram. So in conclusion, this showed that efficacy response were maintained or further improved with Upadhye over 56 weeks, and numerically higher versus adalimumab, with no new safety findings observed with the longer exposure to Upadhye. Next slide, please. So we see data on Upadhye in ankylosing spondylitis. So here, Kishimoto et al. Reviews the efficacy and safety of Upadhye in patients with active ankylosing spondylitis with the inadequate response to NSAIDs over 1 year. Next slide, please. Yes, this study is evaluate the efficacy and safety of Upadhye in patients with active ankylosing spondylitis. This is the 1-year result from randomized double-blind placebo-controlled study with open label extension. So this study is the week 64 data from select Axis 1 study, which was a randomized placebo-controlled 14-week study, followed by a 9th-week open label extension study. So here, 178 patients were included. So of Upadhye 50 milligram patients, 85% patients achieved SS40 at week 64. And placebo to Upadhye patients showed a similar response rate. And of 182 Upadhye recipients, 618 adverse events were reported. Interestingly, there was no reported serious infection such as active tuberculosis and venous thromboembolism or gastrointestinal perforation. So in conclusion, Upadhye 50 mg QD for ankylosing spondylitis was consistently efficacious with no new safety findings over the course of a year. Next slide, please. So I like to show spotlight or topazine abstract by Raman APLAR, specifically looking at the treatment of refractory cases of psoriatic juvenile idiopathic arthritis. Next slide. In this study, they evaluated the efficacy safety of topazine in the treatment of refractory cases of psoriatic juvenile idiopathic arthritis. Key results are like this. This study was from Bangladesh, and they enrolled 27 cases of refractory psoriatic JIA patients. Patients who received the topazine and their disease status was assessed baseline 6, 12, and 24 weeks using J-27. And ancestry-related arthritis was the most common type, followed by psoriatic JIA in this study. Total improvement of the JA-27 score was 83%, 91%, and 96% at 6, 12, and 24 weeks. So among the patients, 70% of the patients were inactive state at 24 weeks. And for adverse event, headache, vomiting, and transient ALT elevation and anemia were observed. So in conclusion, topazine reduced disease activity in patients with JIA with minimal side effects. Next slide.
Okay, thank you very much for your presentation. I'd like to ask you 2 points. One is the guselkumab for PSA. How well does this treatment work in PSA? Yes. I understand the efficacy is superior to placebo. However, what is the impact of a guselkumab treatment in PSA? Is that working well for joint, skin, and also the inhibition of radiographic progression?
Yes, because there is only one abstract, I cannot say exactly, but it looks like that they will show the good results in different aspects of the psoriatic arthritis. So I like to know, because the TNF inhibitors are very effective, and I-17 receptor antibody is very effective. So we would like to see which is the best treatment for psoriatic arthritis later.
Okay.
Different aspects of the
So the guselkumab targeting on P19, IL-23 is the another option for PSA.
Yes.
Okay, thank you very much. And the next question, the second question is that how do you feel about the efficacy of JAK inhibitors in the disease rather than rheumatoid arthritis overall?
For what kind of disease do you think? Ankylosing spondylitis?
Yes, AS, PSA, and JIA.
Yes. But frankly,
is that efficacious?
Yes, frankly, but I have no direct experience with JAK inhibitors about this kind of disease other than rheumatoid arthritis. But if I see the data from others, it looks like that JAK inhibitor is also effective for different kind of chronic arthritis, including ankylosing spondylitis. The problem is that we have no long-term data at this moment.
I see.
So for ankylosing spondylitis, because they should use the medication very long time, we need the safety data about this kind of drug in this kind of disease, I think.
For example, in regarding safety, how about the herpes zoster in this disease, in addition to rheumatoid arthritis? The signal is also detected in this disease.
Yes, I think so.
The signal of herpes zoster.
Yes, because this study is a long-term study, so they did not show much about it. I think finally it is same, but the problem is that maybe it's better because you know the patients, age of the patients in ankle spondylitis is very young, so they may free from herpes zoster compared with our patients.
Okay, thank you very much.
Right.
So we move to next one, the last theme, that is the COVID-19. So we will now enter our last session, which will look at the COVID-19 in RA, vaccines, and teleconsultations, a fitting session to close this Congress review. There were several studies this year focusing on COVID-19. Our first abstract in this session is authored by Kimoto, underlining the first result from the Japan College of Rheumatology, JCR COVID-19 registry. The title here is the COVID-19 in rheumatic diseases in Japan. First result from the registry of JCR COVID-19 registry. Key result in this poster is of 209 cases registered at 64 institutions in Japan. That is COVID-19 patients in rheumatic diseases, 43% RA, 13% SLE. 99% were Japanese and 61% are female. Average age was 62 years. COVID-19 symptoms, 90% fever, 48% cough, 46% fatigue, and 12% taste and smell disturbances. Of more than 200 patients, 34 received oxygen treatment, 9% received artificial respiration, and 6% died. Severe versus mild cases tend to more common in older patients and males, involve higher concurrent prevalence of diabetes, and had a higher steroid use rate. The conclusion here is JCR COVID-19 registry identified COVID-19 risk factors specific to patients in Japan with RMD, where regional prevalence of COVID-19 is much lower compared to European countries. The next poster is coming from Philippines. The title here is Outcomes of COVID-19 in Patients with Rheumatic Diseases in a Tertiary Government Hospital in the Philippines. The key result, the first part, 31 patients with rheumatic diseases were identified among 2,500 total inpatients with COVID-19, 18 male, median age 50 years. An average of 10 days elapsed between acute symptom onset and hospitalization, and comorbidities included hypertension, 11 patients, diabetes 7, chronic kidney disease 7, ischemic heart disease 5, dyslipidemia 2, and cerebrovascular disease 1. The most common rheumatic diseases diagnosis included gout, 15, SLE 9. The 2 patients had bacterial or tuberculous arthritis. The most patients had moderate or milder, moderate 15, milder 8 disease, although 8 had severe to critical disease and 7 died. 4 acute respiratory failure, 2 thromboembolism, and 1 septic shock. So most patients with rheumatic diseases and COVID-19 recovered well from COVID-19 with only a slightly higher mortality rate than the overall PGH rate. The death case is a 7 out of 31 patients. The next poster is COVID-19 vaccine acceptance in patients with rheumatic and musculoskeletal diseases, a hopeful prospect from Malaysia. The questionnaire was given to patients in rheumatology clinic follow-up Queen Elizabeth Hospital, Sabah, Malaysia. Of 230 participants, 81.7% were female, and the mean age was 46.6 years. 98.7% were aware of COVID-19 vaccines, including 89.1% who are fully aware of associated adverse effects. Among the participants, 53.5% refused vaccination due to fear of adverse events related to disease, 85%, fear of disease worsening after vaccination, 70%, and distrust of COVID-19 vaccination, 17%. Participants with higher income, but not age, education level, or employment status was associated with better acceptance. 76% were willing to reconsider 76% were willing to reconsider if more information were provided by the physician. A conclusion here is additional information provided to patients with RMD by physicians could improve COVID-19 vaccination acceptance rate. This is the final poster. Teleconsultations for RMD during COVID-19 pandemic, usefulness, patient response, and prospects for future practice. Key result is the patient who had teleconsultation by telephone and WhatsApp during WhatsApp application and during the COVID-19 pandemic responded to an online questionnaire on teleconsultations. Among the 230 patients, there is the age 18 years old with at least 2 previous physical visits to the hospital. Mean age is 38 years, a little bit younger, as you expected. 30% male. The patients included 80% from rheumatoid arthritis, 40% from described their disease as bad or severe, 40% dependent on the other or teleconsultation smartphone use. 57% missed their scheduled outpatient department appointments. 50% reported worsening of symptoms. 35% needed to consult a local physician for their problems. The majority of patients reported benefit with the teleconsultation service, and 70% wanted to use it in future. A conclusion, teleconsultation was considered a useful alternative to physical consultation with a high satisfaction rate by patients with rheumatic diseases. So, discussion. Do you have any question or the discussion raise the discussion point from Professor Lee for COVID-19?
Because we have not collected the data about COVID in our patient, I have no complete data. But I'd like to know whether, do you think that patients with rheumatic disease has the incidence of COVID is higher than general population in terms of incidence? How about the severity? Our patients has more severe course if they are infected with the COVID. What is your impression?
Yeah, to me, for example, the JCR registry data, the death case is 6%. Oxygen requirement case is around less than 40%. That is, seems to me a little bit higher than general population, because the patient age is higher than general population, of course. I think that the simple comparison between the severe case and fatal case to general population is not incorrect because of the different backgrounds. If you adjust the patient background to general population, maybe the severity rate or fatal rate may be comparable or a little bit higher for RMD. But we cannot conclude a definite conclusion by such as the registry data. And
Right.
it is also supported by the global data, I think.
Yes. I see.
How about your impression in Korea?
I have no concrete data, but I have
Okay.
several COVID patients. But the interesting thing is that I have never seen or heard about the patients who are taking high dose immunosuppressant. The patients usually those rheumatic patients who is taking usual medication, such as gout or mild rheumatoid arthritis, osteoarthritis, something like that. So I didn't directly experience the patient who is now taking highly immunosuppressive status.
Yeah, thank you very much. So we need to collect data, much more data from other countries, particularly in the East Asia, like Korea, China, Japan, as well as the Southeast Asia and South Asia. In addition to such countries, we need to data from Australia and New Zealand, and from the different the ethnic backgrounds. Anyway, we need to collect data, continue to collect data, and we need to compare the data between countries, between the different patient disease and different patient background, treatment history. Thank you very much. Do you have any additional question? Is that okay?
Yes, I'm fine.
Okay, yeah, thank you. Thank you very much. So there were also many industry symposium of highlight in a CSF APLAR symposium. One in particular by Professor Kevin Winthrop from the Oregon Health and Science University, a CSF steering committee member, chaired a CSF APLAR symposium discussing the use of JAK inhibitors in various disease states, including RA, SPA, SLE, and COVID-19. If you missed the symposium at APLAR this year, I strongly recommend you to visit the CSF website to catch the on-demand version of the video with new and extensive full discussions now. Why don't you visit this? So I'd like to summarize all of the review, and I would like to close the session. This is it for our Congress review. APLAR 2021 Virtual Congress certainly brought diverse topics and research. Even during the ongoing pandemic COVID-19, it did not stop us from learning. Thank you very much to modern technology, and we can outreach our knowledge virtually. Remember, you can visit our website to see the full CSF APLAR 2021 coverage at www.cytokinesignaling.com. We hope you enjoyed our overview of the APLAR 2021. See you again next year.